Styres Loft Biaso, Odedoni Biaso, Omehoika. I am the Styres Loft. My spirit name is Odedoni. I come from 6 nations. I come from the Cayuga Nation and the Killdeer people. And it's my privilege and honor and pleasure to be here. It really is an honor to be here. Thank you so much, Gurumi, for you and the people that you work with to consider me for speaking here with you today. It's a real honor for me. I've identified with the speakers. I feel so good here. I work in mainstream. I'm not used to working in mainstream. I work in mainstream. I'm not used to that. I've been there 5 years now, getting a little bit more comfortable. But I come from the communities. I've worked most of my career in the Aboriginal communities, in the Hamilton area, 6 Nations area, and worked for small nonprofits, struggling nonprofits. And now working in the healthcare system at the largest employer in Hamilton, Hamilton Health Sciences. I am not around the beautiful items in our culture on a daily basis. So the smudge, the elders, having the items here honored, it fills me up. So I am very honored to be here because I'm filled up. Because, as Aboriginal people, I hear all the time that we do that for one another. And within the healthcare system that I work within, I needed to develop a common language. I'm not going to visit an elder. I say I'm going for a cultural consultation. And then that's honored and it's put in the work plan and I'm able to do that. So it's very, very good for me to be here. So thank you very, very much. I've identified with everyone that's spoken so far. Now, I'm just going to see if I can. So I start with this slide, and the first word is scano, and that's for my language. And I just put that up here, and I see that there's a bookmark out in the hallway as well as a handout, just to show some of the diversity within our area. And so scano is really a very complex word. It comes from the Cayuga Nation of the Iroquois and Haudenosaunee peoples. And really it speaks very affirmingly and it speaks very positively, because what it means is, in the English language, means I'm so happy to see that you're with the great peace in my body and spirit. And that makes me very happy. And that's what scano means. And so when I say scano, that's what I'm saying. I'm affirming that you're well. Now if I was going to ask, how are you? I would say, scano again. Are you with the great peace? So if I say scano to you, you can say it back to me. So scano. So to honor, the other nations, Sego is Mohawk, and Ani and Bujo would be the Ojibwe, and also the Anishinaabe. Saguli for the Oneida people, and Tanzania, I'm told, are the Cree. So, and native to Marlyn is to honor Gertie May and her nation from the Mi'kmaq people. So just a bit of an overview, just to talk about demographics, Aboriginal cancer care, Aboriginal patient navigator services, diversity, accessibility, referrals, accountability, and best practice. I do have a very, very ambitious PowerPoint, so I'm going to be trying to get through this in a very timely manner. You know what? I used to talk a lot slower before I worked in mainstream. Very much so. And I've had people that hadn't seen me for a few years, and they see me now, and they really notice the difference. Because literally, when I'm asked to go and do a presentation with the disease site teams, I have 5 minutes. 5 minutes is 5 minutes. So I learned very quickly to be able to be concise and economical and really fast in my speaking. So I'm going to try my very best to be able to get through the PowerPoint for you. I work at the Juravinsky Cancer Center in Hamilton, and at the Juravinsky Cancer Center, so only the one thing I have to read, I'm going to read this. We see, the Juravinsky Cancer Center sees about 7,000 new patients a year. It's a very, very, very busy place. Unfortunately, it really is. There are 800 visits a day. The chemotherapy suite sees about 120 to 175 people per day. Approximately 4,500 new radiation therapy cases are treated annually, and approximately 350 patients are treated daily with new state-of-the-art radiation equipment. So within the region that the Juravinsky Cancer Center is in, we serve about 1.4 million residents,
in the region of Hamilton, Haldimand, Norfolk, Niagara, Burlington, and Brant. Now, we created this map. It's the Aboriginal Services map, and it has listed the Indian Friendship Centers. It has the First Nations of 6 nations of the Grand River Territory, where I'm from. And nestled near there is the Mississaugas of the New Credit Nation, First Nation. We have the Métis Nation of Ontario. We have Dave Wadidesne, the Aboriginal Health Center. We have also the Native Horizons Treatment Center at the bottom in the Haldimand area on the New Credit First Nation. So we're trying to encompass, to show the diversity within and also those autonomous services that are available in the Aboriginal communities. Now in this region, 6 nations of the Grand River Territory, we have a very low guesstimate that there are approximately 40,000 people in the area of Hamilton, Niagara, Haldimand, and Brant, which is LHIN 4, Local Health Integrated Network 4. And there are approximately 10,000 people in the region. That's very, very low. And Hamilton, about 15,000 to 20,000, because we do still have a migratory population. In Brant County, there are about 7,000 people, and we went to, when I first came to the Juravinski Cancer Center, they were quoting 25,000, and I knew that that was really, really low. So I consulted with Cancer Care Ontario, I consulted with the LHIN, and I consulted with the Hamilton Executive Directors Aboriginal Coalition and 6 Nations, and also the Mississaugas of the New Credit First Nation. So this is something that we are agreeing upon, but it's probably grown since then, because I developed this probably in 2006 or 2007. And in Niagara, we do have a really strong connection to 6 Nations because of the border that now exists between the United States and Canada. And so we have a lot of the Haudenosaunee peoples in the Niagara region, and it's about 5,000 people there. In the Mississaugas of the New Credit First Nation, about 700. It's closer to about 1,000, they say. Now, within this area, we have Cree, Ojibwe, Anishinaabe, Haudenosaunee, or Iroquois, as people know us as well, Métis, and Inuit. Not very many Inuit, but some. We are a multinationalism within our LHIN, within our region, and as in this area as well. So I've talked about the diversity, and it's really, really important to do that. So we have the Cree, Swampy Cree, Anishinaabe, Ojibwe, and we know that with the Ojibwe, I'm told that there are at least 40 dialects in the province of Ontario. And with the Haudenosaunee, we have 6 distinct nations. That's the Mohawk, Onondaga, Oneida, Cayuga, Seneca, and we also have Tuscarora, a representation on 6 nations, and we have several family dialects as well. So we have a very diverse language base as well. We have diversity within. We have urban and reserve. So when I talk about 6 nations having 10,000, there are probably that same number off reserve. So on reserve would be between 10 and maybe 13,000, but off reserve would be about the same. So a lot of times when I talk with people within the mainstream, more and more there's awareness of symposiums like this and presentations, but they always think of just the First Nation on reserve. And so, to be able to explain that it's on and off reserve, it's not just on that little parcel of land. There are Métis and status and non-status and Inuit, Christian and traditional spiritual paths. And we have people that have no affiliation or have no real connection with any type of a spiritual path. There are some that use traditional and some that use Christian as well. So it's very diverse. So Aboriginal Cancer Care, I'll just talk a little bit about that to give some background as to how this program began. Now, there was a study. It started with a study in 1968, and it talked about cancer incidence and mortality in Ontario's First Nations. And really, it started with the First Nations in Ontario because we were able to use specific postal codes through the Department of Indian Affairs. So Cancer Care Ontario endeavored to do this. So we took a snapshot between 1968 and 1991, and we found that there were very alarming rates. We found that even though for the sites for male and female, they were similar to the rest of the population, We found that for gallbladder and kidney, it was almost twice as high for the incidence of cancer with Aboriginal peoples in Ontario. And as well, cervical was still a real concern because it was like 1.73% higher for Aboriginal women. So we know from the study that cancer among Aboriginal people is one of the leading causes of death. Incidence is growing at a more rapid rate. It's not spiking like this on a graph, but it's still gradually rising. So the incident rate is still rising today. So that's really, really alarming. And we were told in 1991 that if nothing was done, that in about 10 to 20 years, it would surpass the rest of the population. And that did come, unfortunately, to fruition in 2001. For colorectal cancer among Aboriginal males in Ontario surpassed for the rest of the population. Lung cancer is really, really on the rise and is surpassing for the rest of the population as well. And we have the lowest 5-year survival rate. Now, I don't know if people understand when I say 5-year survival rate. Many people in the room may. But with cancer care, what we do is when someone goes into remission or they feel that they have a cure, they follow the person for 5 years. They'll come maybe every 3 months, then every 6 months, then every year, then every 2 years. And when someone comes for 5 years, they really feel that they are a survivor, that was a real success for the treatments. Now, the 5-year survival rate, if we just look at breast, and we just look, we look at in Ontario for breast cancer, we have the lowest survival rate. But if we look into the United States, the southwestern United States, and the Cheyenne and the Navajo women, those areas, the rates are exactly the same. Now, we do not believe we have a predisposition. There are some studies that are actually happening right now to look at that. But we know that we present late. And many of the things that people have heard here this morning are part of the reason for that. It is a foreign system. It's very hard to ask someone to come to a cancer center, even the word cancer. So there's so many myths and misunderstandings, and there's so much stigma around the word cancer. And so when someone is diagnosed, it's usually when they're really, really suffering. I cannot believe how our people can really hold themselves so tight. You know, sometimes there's a new diagnosis, and the person will pass within a few weeks because they've been holding that, even from their family. So their family knows that something's just not right with that person, but they really hold themselves with a lot. And so we present late. We present not when it's stage 1 and it's just in one little area that's easy to treat. We come at stage 3 and stage 4 with the cancers. And so it's very, very hard to find cures. So, we need to talk about these things. And, a lot of these things are very uncomfortable, but we have to talk about them. And they'll get more and more comfortable. And then we can have, the around the table with tea talks around cancer too. And it won't be such a scary word. We have to take that fear off of cancer. Historic overview. So the study came out, and quickly after that, in 1996, the Joint Cancer Care Ontario Aboriginal Cancer Committee, or JOAC, and it's still in existence today, was formed. And they came out with a report, and I have that just to show you, but I don't have it on the slide. But this is available through the Cancer Care Ontario website. And shortly after that as well, the Aboriginal Cancer Care Unit, ACCU, of Cancer Care Ontario was formed in 2000. And one of the first things that the Aboriginal Cancer Care Unit did was to initiate a needs assessment across Ontario, and it was quite extensive. We went to all the communities and talked with survivors, talked with families of survivors, talked with people that had been touched with cancer, talked with frontline workers and physicians and teams, health teams, and also talked with the traditional people. And the Aboriginal Cancer Care, It's Our Responsibility Needs Assessment Report came out in 2002. And this is what it looks like on the website, if you want to take a look at this. This is just a summary. The report is about an inch thick. So there were a lot of things that were recommended. There were a lot of things that were learned from that needs assessment. And the result was that there was a need was identified for Aboriginal specific services to be visible within cancer centers. And for example, Aboriginal navigators. Now, along with these findings, there was a recommendation that there should be cultural competency training, that it was really, really important for that because it had to do with patient safety. People were not coming to cancer centers. They were not coming when they noticed something, or they were not going for screenings. So the Relationship and Development Training Program was developed, and it was developed through McMaster University and the Northern School of Medicine, and through Northwind Partners, and they came up with the program. The Juravinski Cancer Center, that's what JCC stands for, the Juravinski Cancer Center Aboriginal Relationship Development and Training Committee began with champions identified at the Cancer Center in 2004, in December of 2004. And so we have physicians and radiation therapists, nurses, social work on that committee. And Aboriginal Partnership was established in June of 2005. Now, between that 6-month period, before Aboriginal partnerships were invited to come to the table, there was extensive cultural competency training baseline. So there was cultural competency training 101 that was done with the champions that were identified at the Cancer Center. Because there was such ignorance, and they didn't want to invite Aboriginal partners to come to the table and make faux pas or do anything offensive. So they did the cultural training. So even before this program came, and before I was part of this project, there was the establishment of an understanding. There was an understanding of the issues, there was an understanding of the culture, the uniqueness, the differences, the similarities, all of those things. And also a cross-cultural exchange, because with that training program, we learned about the culture of the Juravinski Cancer Center, the Cancer Center itself. So it was not only learning about the culture of the Aboriginal peoples, but also the culture of the hospital system as well. Now, the collaborative efforts of the Juravinski Cancer Center and the Six Nations Health Services resulted in the implementation of the Aboriginal Patient Navigator project. And it's to provide culturally sensitive, supportive, and advocacy services for Aboriginal people with a diagnosis of cancer and their families, and I'll add, and the nations. Because when we talk about, those things that happen in our communities, the births, the deaths, all of those things that happen in communities, we feel it deeply because we are communal people. And so I add the nations as well. The overall goal is to improve the cancer care experience and improve the health status of Aboriginal peoples, and that is very parallel with Cancer Care Ontario's Aboriginal Cancer Care Unit as well. Now, I talk about permanence and stability because it started out as a pilot project. And we know about pilot projects in Aboriginal communities. And we know that pilot projects sunset and they don't continue. Even though we have a needs assessment, it could be a beautifully designed program. But maybe for 1 or 2 or 3, maybe 5 years we'll have the program. When the program ends, it's like a re-traumatization because we know what we're missing. We really, really know what we're missing because it's no longer there. We really, really talk a lot about sustainability in our communities, and that's what, where the downfall is, sustainability. So it was a pilot project between 2006 and 2007, and it was funded by Cancer Care Ontario. And we learned a lot from the Northern Project, from the Regional Cancer Program in Thunder Bay. We had 7 pages of recommendations, and so we used that. We started with a blank slate. We just started with a blank piece of paper, and then we started from there. And then the Juravinski Cancer Center had me as, through a contract position, so that continued from 2007 to 2009. The role became a permanent, full-time program role in June of 2009. It's really important to talk about this because of the permanence and stability equaling credibility in the eyes of the Aboriginal community. Really wanting to know, I know that when it was a pilot project, I really had to learn a lot. There was so much for all of us to learn because it was a brand new program for me, brand new role for me, for Hamilton Health Sciences as well, and also for the Aboriginal community. Here I was now on staff. I was no longer working in the communities in an organization. I was not coming from an outside organization to do the patient advocacy, which I had done over the years. And I have colleagues in the communities that still do that. I was on staff. So there was a lot to learn from that. And I know within that first year, there was almost like an arm's length. We're going to wait and see what this is all about. You know, what's that lead doing up there? You know, she's up at that hospital now, and she's got this badge, you know, what's that all about? It's a pilot project, what does that mean? And so there wasn't a lot of engagement. There wasn't a lot of embracing. You know, there was a lot of respect. But, you know, just kind of step back and kind of watch. But now it has been, since, you know, in October it became, you know, I've been there for 5 years now. So the role became a permanent full-time program. And also it is the very first cultural specific program or role for Hamilton Health Sciences. And we are funded by the Hamilton, Niagara, Haldeman, Grant, Lynn. I'm in supportive care, and it's an interdisciplinary team. We do not treat the cancer, we treat all the other parts of the person's being, and their social and financial, all of those. So these are my colleagues, and and I'm in the red in the middle. I used to have this crazy orange streaky hair. I used to, I got my hair done, and I said to my daughter, I said, I've got stripes. She goes, Mom, it's called streaks. But I kind of got past that stage, so I got back to my natural name. So access to care. So this is, I have some information in the back there. So you'll see a yellow sheet of paper if somebody who picked up that information. And this is our model of care. So access. It's only about accessibility. So under patient support, networking, and cultural needs. And I'll just go into these just very, very quickly. Under patient support and advocacy. We have support, you know, I actually go to clinic appointments if the person is wanting me to go, even if they have family there. I can be a second set of ears with them and go to the clinic visits with them. And if they want to talk about accessing traditional cultural healers, then, you know, I'm the one that would be able to help facilitate that with them in any which way that they feel that they need that. And also to navigate appeals processes such as the, you know, Health Canada's First Nations and Inuit Health Branch, non-insured health benefits. And also access to information and to resources that are culturally specific, that are informational, and that, you know, that is really simplified and easy to understand. And all across these areas, and this is not the end-all list, so diagnosis, treatment, medications, diagnostic testing, and also discharge planning. And under networking, to create Aboriginal cancer care awareness, absolutely, and committee and network involvement, and to enhance communication between the Juravinski Cancer Center and Aboriginal communities. Under cultural needs, and I was taught many things. I was really part of the Friendship Center movement for a long time in my career, well over 10 years, and went to many trainings. And I would, you know, hear Sylvia Miracle talk about Ongwe Hongwe Neha. You know, all of those things that we're born with, right? Everything that we have, like our unique talents, all of our ancestry, all of that history, you know, all of that heritage. And so I drew this, and that's, to me, the Ongwe Hongwe Neha under cultural needs. So cultural needs, respect for Aboriginal culture. So having those conversations, continuing to have the cultural competency training and, you know, developing capacity for that, awareness. Policy and protocol development and smudging protocol. We have a smudging protocol that took about 10 years to develop, and it went through many hands. And in December of 2009, it actually became a legitimate protocol of Hamilton Health Sciences. And we are willing to share that with anyone, because that was one of what the Aboriginal community said, that we would share that openly. And access to traditional healing, example, the Six Nations Family Health Team, which has traditional healers as part of their family health team. And also under cultural needs, Aboriginal Patient Navigator within the Juravinski Cancer Center. Now, you know, we have the symbolism of the culture. We have the beautiful baskets here, which are not just to, you know, make the place look beautiful. We have many of the items in this room that are from the culture. We are so rich in our symbolism. And so I came to understand that the need that was identified to have workers in the cancer centers was really important as far as symbolism. What do I represent? You know, what do I represent as an Aboriginal person in a cancer center, on staff there? You know, for that person that's coming, the person that wants to learn about prevention, what do I represent? You know, what am I a symbol of? You know, we talk about all of these items, and it talks about, you know, our heritage, that there's going to be safety there, that there'll be confidentiality, all of those 7 grandfather teachings, right, all of the good teachings. So that's why it's really important to have someone right on staff. And spiritual caregiving. You know, I really, really like that. I really like that terminology, and I'm just learning about that because I'm actually taking a course on hospice and palliative care. I find that coming into this role and into this work, I have a real passion for palliative care that I didn't realize from before. So I really appreciate Dr. Cook, you're talking about death and how, you know, natural death has been taken out. And I'm taught, you know, and told that, you know, for someone to die within a hospital system or a medical system is looked at as a failure. So you do everything you can to make sure that that person doesn't die. So spiritual caregiving is when we have those conversations with people, when they're questioning, you know, why did this happen to me? What does this mean? You know, or having the hopelessness and the despair, having those conversations. So I say, I acknowledge that we all do spiritual caregiving because we all share stories with one another. Not only in the Aboriginal community. We sing songs, we share, we yell, right? All of those things. We are spiritual caregivers. Accessibility is really, really important. I don't just sit at my desk at the Cancer Center. That was one of the first things that we established. I go out into the community. When someone is diagnosed or there's a suspicion of cancer, they don't necessarily all come to the Cancer Center. There are clinics within the communities. They may have surgery and then they never come to the Cancer Center. But, you know, I would be able to perhaps help them with different things along their journey. So we still encourage at the source of diagnosis to have them referred to me. It doesn't need to be a presenting problem, doesn't need to be an issue. So that there, you know, can be that contact. So I will go to wherever, you know, is mutually safe and secure for all. And I can go to wherever the family, the person would feel comfortable for me to go. I've gone to palliative care facilities, I've gone to do home visits, I'm at Six Nations, I've got people at Tim Hortons, not Starbucks yet, but Tim Hortons. And clinics at Six Nations and also Daidwada Desne in Hamilton, the Aboriginal Health Center. So I acknowledge Ontario Federation of Indian Friendship Centers for the Life Cycle Responsibilities Wheel, and I've adapted it and with permission from them. And so even though I do see people mostly as adults, middle-aged, older adults, I would really be, you know, being supportive and serving all of the population. Many times, you know, someone will come and they'll say, "How do I tell my granddaughter that I have cancer? How can we talk to our son about our daughter having cancer?" So, you know, having those opportunities to talk with the families and the privilege of walking, like Dr. Cook had mentioned, to go for a walk with a young person. When you're just walking side by side and you can talk, you know, so having that privilege of doing that as well. My cards are on the table and my information is out there. That's my extension. You know, not all of the nurses and doctors can afford really to have their true extension on the card, where they will go through an administrative assistant, a secretary, but that extension is really mine, so it'll come right to my phone. There does not need to be a crisis. Over and over and over, I need to say this to my colleagues. There doesn't need to be. It really, really is about awareness of this program and access. I've had people in that first year, we learned from that first year that people were saying they were really glad they met me. When there wasn't anything happening. Maybe 2 weeks later or 2 months later, they said it was really easy to pick up the phone because they had met me, we had broken the ice, we'd actually spoken, and they could call me. And so, you know, we really wanted to learn from that. And promotion of the program and the awareness of the availability of culturally specific services at the Cancer Center, you know, doing presentations with family physicians, healthcare professionals within First Nations and urban communities ongoing. And the result was more timely referrals, you know, from the source of diagnosis. There are many times junctures within the cancer journey. And one of the most stressful times is when someone is waiting for a diagnosis. If there's only a suspicion and they do not know. That has, through studies, been shown and research been shown that that's one of the most stressful times for people when they don't know whether they have cancer or not. They're really, really just hanging. And so having those timely referrals, we can talk about the what ifs and talk about all those things. And the supportive rapport is established early, and the person-centered care settings to make sure that, you know, wherever the person feels comfortable, that it's really about the person.